Hello, everybody, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for this webinar. Today, we'll be featuring Jordana Bernard and Tim Wright of InTouch Health, and they'll be presenting on telehealth reimbursement in 2019. Jordana Bernard has 20-plus years of progressive leadership in the telemedicine industry. Jordana currently serves as the Director of Policy and Public Affairs at InTouch Health, a leading global telehealth services provider. In this role, Jordana executes strategies for key telehealth advocacy and policy initiatives. Prior to joining InTouch Health, Jordana served as Chief Program Officer for the American Telemedicine Association, overseeing strategic objectives to advance the telehealth industry in education, accreditation, practice guidelines development, and alliances with professional societies, governmental agencies, payers, and industry. Jordana received a BS in biomedical engineering from Boston University and an MBA from Marymount University. Tim Wright has over 20 years of healthcare industry experience in operations, marketing, strategy, and new product development. Tim was a member of the original founding team at InTouch Health and has played many roles over the evolution of the company. He currently serves as Chief Strategy Officer. Prior to joining InTouch Health, he worked as an operations general manager for what is now HCR Manor Care. He also held positions in marketing, corporate strategy, and new product development at Manor Care and at Marriott International. Tim received an MBA from the Darden School at the University of Virginia and a BA from the University of Washington. We will begin this webinar shortly, but first, a few notices. You have all been auto-muted. If not, please make sure to mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget with the question mark icon, which covers common technical issues. You expand the slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. During the webinar, you'll be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website, and a link will be posted via email later on during this week. This webinar presentation should last around 60 minutes, including time for questions and answers. And now, I'd like to turn it over to Jordana and Tim.
Good morning, everyone, or good afternoon to you on the East Coast. Let's just dive right into this. I'm going to moderate for our conversation today. So, Jordana, to begin with, there have been a lot of moving pieces in telehealth policy. 2018 has been a landmark year for new policy. But just to set the stage for those who maybe don't have the full historical context, can you give us a little bit of a high-level overview of telehealth reimbursement for Medicare, Medicaid, managed care, commercial payers up until the legislation that's passed in 2018?
Yes, absolutely. At the federal level, the rules for reimbursement are outlined in Section 1834M of the Social Security Act, which was enacted about 20 years ago. And first, the law says that Medicare patients must be located in a federally designated rural area, which essentially restricts payment to a very small population. Second, it limits the setting or originating sites where the Medicare patient must be located when receiving care. It also specifies the types of healthcare providers who are allowed to provide services, and it requires the services to be delivered using real-time interactive video with just a couple of exceptions. And lastly, Medicare only reimburses for a specific set of approved services, which they update annually. Medicare does pay an originating site facility fee for telehealth services. And then at the state level, it's a brighter picture because states have the ability to set their own rules for how telehealth is treated. And over the last few years, we've been seeing state Medicaid programs being more progressive. and trending towards offering more reimbursement opportunities for telehealth and eliminating unnecessary restrictions and making their policies more telehealth friendly. There's a range in, how states are reimbursing, and it goes from, for example, a Medicaid program in a state like New Jersey, which only reimburses for telepsych services, to a state, for example, like California, that reimburses for live video across a wide variety of medical specialties in any setting. On the commercial side, we're seeing payers trending towards offering broader coverage of telehealth services, although how much and for which services they pay for can vary, again, widely by state. And states are also creating their own reimbursement rules for the commercial payers, which often involve parity in coverage of services, though not necessarily in reimbursement.
So from a federal perspective, it sounds like the reimbursement has been highly restricted historically, and states are a little bit of a catch as catch can kind of a scenario. Is that fair?
That's right. That's right. Yeah. Mm-hmm.
Go ahead.
So I was going to say that. Yeah. Right.
Yeah, sorry, I'm messing you up here. So with that backdrop, let's talk a little bit about the momentum that's building at the federal and state level regarding reimbursement. Can you give us a little bit of a snapshot of what's happening at a high level?
Yes, at the federal level, it has been quite a year. We've seen a rapidly changing policy landscape that's been moving in a very positive direction, and there has been more legislative activity that includes telehealth than ever before. In fact, we've seen an increase of about 66% in the number of these bills that are in play that include telehealth compared to last Congress. Clearly, our lawmakers are really interested in telehealth, and they've been focused on chipping away at that 1834M set of restrictions and also moving us further down the road towards value-based care. And then on the regulatory side, we're also seeing tremendous interest around telehealth. For example, we've been hearing from both Secretary Azar and Administrator Verma that telehealth is a high priority, and not just for fee-for-service, but also with respect to the key role that telehealth can play in the value-based care models. And then at the state level, again, we're seeing progress, and today every state offers some type of live video coverage and reimbursement for telehealth under Medicaid, and the vast majority of states have a private payer telehealth parity law in place. So as evidenced by everything that's happened this year in 2018, our policymakers are showing their attitudes have changed significantly, and telehealth is really being seen as a solution to dealing with many of healthcare problems, the issues that we're facing in our nation today.
So that's a good backdrop. Let's dive into the specific legislative changes and walk through them one by one. The first big win this year was early in the year, the passage of the Bipartisan Budget Act of 2018. This rule has several components, first of which was surrounding kind of telestroke and dialysis care. Can you characterize, what was historically the context for those use cases, and then what's happened in the Bipartisan Budget Act?
You bet. So historically, reimbursement for telestroke services has been severely limited mainly because of that rural limitation set by 1834M. And to give you an idea about the impact of this rural policy, about 80% of all strokes in the U.S. occur in the Medicare population, and of these people, about 90% of the stroke victims show up in non-rural emergency departments where there has been no payment to date. So with passage of the BBA, the rural restriction is lifted, which will then enable payment for every stroke patient in every hospital across the nation. The law also added the ability for mobile stroke units to serve as eligible originating sites. And similarly, for patients with end-stage renal disease who are receiving home dialysis therapy, the rural limitation will be lifted, which will allow providers to bill and get reimbursed for clinical assessments by telehealth into hospital-based or standalone dialysis centers, regardless of geography, and then also into the patient's home, which were both added as eligible originating sites. These two payment policies go into effect starting January the 1st of 2019, so just a few short weeks away. And the impact really is, I think, going to be very, very big and very significant, in terms of, we're finally getting payment in place, and this can really make an immediate impact on both patients and providers, in terms of allowing programs to initiate these services, as well as, allowing those who've been delivering the services without getting paid by Medicare to finally be able to bill.
Great. So we talked about those first two elements. As we think about value-based payment models, also included in the Budget Act were changes to Medicare Advantage and accountable care organizations that go into effect, I think, January 1st, 2020. Can you kind of walk us through those specific provisions and how they incent telehealth?
Yes, they do go into effect a year later in 2020. To start off, let's talk about Medicare Advantage plans. And today, about 20 million Medicare beneficiaries are enrolled in these types of private plans. It's just a little bit over a third of the Medicare population. And to date, these plans are only required to cover and pay for telehealth benefits that are comparable to the benefits that are included in original Medicare. And as we know, these are very narrowly defined. And so if a plan wants to offer additional telehealth benefits that would go above the basic level, such as allowing enrollees to receive care in urban areas or at home, they have to do this through a supplemental plan. What the BBA does is it allows these plans to have more flexibility. They can build these additional telehealth benefits going forward into their basic bids rather than having to include them as supplemental benefits. I think CMS is counting on this new policy to incentivize plans to adopt more telehealth in their benefit programs. And the upshot of all of this is that as plans move forward to take advantage of these new opportunities to use more telehealth, there will then be more reimbursement for healthcare providers who are delivering the services to MA plan enrollees. The question will be, though, how quickly these opportunities will be adopted and implemented by the plan. So we'll see how that goes. But here is an opportunity for providers to reach out and engage with their plans now and to talk about telehealth and start to encourage them to take advantage of these new opportunities to build telehealth into their plans. And then for accountable care organizations, the ability to use and get paid for telehealth services has also been limited, except for a few types of ACOs, like the Next-Gen ACO, where Medicare allows more flexible use of telehealth in urban areas and in the patient's home. So under the BBA, these other types of performance-based ACOs will have the same level of flexibility, like in the Next-Gen ACO, to use telehealth for their patient populations and to get paid for those services. The proposed rules for the MA provision are now open for public comment. They're open through December the 31st. So again, here's an opportunity to weigh in on this policy. The period for public comments has closed on the ACO provision, and we do anticipate the final rules for these areas will come out most likely next spring. And then I'd like to just touch on bundled payment models. These are another value-based model that CMS has been focusing on. Recently, CMS launched the Bundled Payments for Care Improvement Advance, the BPCI Bundled Payment Program. This is a voluntary program. It launched on October the 1st. And there is a telehealth waiver for this program, so that is really terrific. And again, as evidenced by the legislation and the regulatory actions that are being taken by Congress and CMS, we can really see that they're pushing the industry or trying to push the industry toward using telehealth more and more in these capitated and value-based payment models, because they're recognizing that telehealth can improve care delivery in a more convenient and cost-effective manner.
So that's a great overview. Just for clarity, Jordana, the Bipartisan Budget Act really is referencing Medicare reimbursement with the addition of Medicare Advantage and ACO, but it does not affect Medicaid or private payer payment. Is that correct?
That's correct.
Yeah. So let's keep moving, and we'll talk now about the VETS Act. So this is another bill that passed, and some have been asking how this affects the private sector. So can you describe a little bit the VETS Act, and does this impact the rank and file physician or only physicians that are part of the VA?
Yes, the VETS Act went into effect in June, and it allows licensed healthcare providers who are employed by the VA to practice medicine using telehealth anywhere across the U.S. and across state lines with a single license. So you have to be an employee of the VA, a licensed healthcare provider. So the legislation, will enable veterans not only to receive more timely access to healthcare services, but they'll be able to do this in their own communities and also in their homes.
Perfect. So let's go to the next one on the list here is what was referenced as the opioid bill, but I think it's actually called the Support Act. That was, came online and was passed actually really fast. Can you talk about how it impacts telehealth?
Yes, this did go through the process at really quick pace, rapid pace. The law expands the use of telehealth for treatment of substance use disorders and co-occurring mental health disorders by lifting that rural geographic requirement. And it also adds the home as an eligible originating site, which will open up payment for these types of services in any geography across the nation. And this provision goes into effect July 1st of 2019. And the Support Act had a second telehealth provision that basically put a one-year deadline on the DEA to finally get the special registration set up for telehealth providers. And this is something we've been waiting for a really long time, I think about 10 years. And this is also very important because it will make it a lot easier to prescribe controlled substances without being required to have an in-person initial visit with the patient.
Okay. Hey, so a question that's come in. Do you know, Jordana, if the Support Act just references Medicare reimbursement, or does it stretch beyond Medicare?
That is a good question. I believe these two provisions just focus on Medicare. I'd need to do a little bit of research just to see if there are other provisions in the bill that do address the Medicaid population. So that's something we can get back to the person on. Yeah.
Okay, we'll come back on that. So, okay, so we've gone through the Bipartisan Budget Act, the VETS Act, the opioid bill. You know, what else is going on from a legislative perspective at this point in time?
Right. We have a few other telehealth bills. They're in relatively early stage. The first one is called the RUSH Act. And this bill focuses on providing on-site acute care in a skilled nursing facility with telehealth support from an emergency medicine physician. And the aim of this bill is to try to prevent unnecessary hospitalizations and emergency department visits, which is a really big problem, we know, for the healthcare systems, where roughly 20% of hospital discharges to SNFs bounce back within a 30-day period. And so this could be avoided if SNFs had access to more advanced healthcare, which could happen with telehealth. Then there's a bill called the Mommies Act that was introduced in the Senate, and this is a congressional effort to try to get states to adopt more favorable policies for telehealth to help improve the high maternal and infant mortality rates that we have here in the U.S. And there's another bill that was introduced in the Senate called the Rural Moms Act. So this one focuses in along the same lines to try to improve obstetric care in rural areas. And then finally, I wanted to point out a new bill called the Access to Genetic Counselor Services Act of 2018, which was recently introduced in the House. And this bill will provide expanded coverage of services provided by genetic counselors, including services delivered through telehealth under the Medicare program.
So lots of activity, way more activity than we've seen in any prior year around on the legislative side. And just to kind of recap a little bit, because I'm looking at questions that are coming in. So for the Medicare population, which has historically been where reimbursement has been limited, highly limited by this rural restriction and then by a series of CPT codes, what we're seeing is, stroke payment for all Medicare eligible patients or all Medicare enrollees across any location, any hospital emergency room, and even ambulances. We're seeing this opening up for dialysis. We're seeing it opening up for treatment, for opioid treatment, and there are a series of new initiatives around like skilled nursing facilities and so on. So we're seeing a significant change at the legislative front around the encouragement of telehealth for the Medicare population and therefore for Medicare Advantage and so forth. So we've covered that. Let's shift gears and talk about CMS. So CMS is taking action on their own, and so could you talk could you talk a little bit about the 2019 physician fee schedule, which is an annually published schedule, and what's been going on for telehealth and remote patient monitoring coming from CMS on that fee schedule?
Yes, wow. It's been an incredible year of the proposed payment policies for telehealth that are outlined in the 2019 physician fee schedule. These represent a major shift for CMS and a sea change, really, in attitude towards telehealth. And what's most significant about the physician fee schedule are CMS's decisions to pay for new types of telehealth services and remote patient monitoring, with none of these new codes being subjected to the rural requirements or the other 1834M telehealth limitations that have been placed on traditional Medicare telehealth services. So this means that providers who are delivering these new services will not be tied to any arbitrary geographic restrictions or settings, which will then allow providers to reach their patients wherever they're located.
So let's walk through the three new payment categories. The first was something called a virtual check-in. Can you talk specifically about what it pays for and how it will work?
Yes, this first new category, which Medicare defines as a brief communication technology-based service, as you said, is a quick 5 to 10 minute virtual check-in with a patient, really to try to see if an in-person office visit can be avoided or whether it's actually really needed. Because if it can be avoided, then it's going to save both CMS and the patient money. So this is a real-time synchronous interaction, and CMS will allow a telephone-only interaction. In addition to, they'll allow two-way audio interactions that are enhanced with video or other kinds of data transmission, as long as the HIPAA requirements are being met. These are patient-initiated interactions for established patients only. And virtual check-ins are only reimbursable by physicians or other qualified healthcare professionals who are eligible to bill for E&M or evaluation and management services. CMS did set a specific time frame around when these services can be billed to be reimbursable. The virtual check-in cannot originate from an E&M service provided to the patient in the prior 7 days, nor can it relate to an E&M service or procedure in the following 24 hours or soonest available appointment. There is no limitation here in regard to any particular specialty or application area. So this service could be used in many different ways, but to just name a few, it could be used for post-acute consults, including specialist or primary care follow-ups, or direct-to-consumer visits for established patients. And for this particular category, CMS finalized the non-facility payment rate at $15 per visit.
Okay, so that's the first one, virtual check-in. The second one, I think, is more of a store-forward scenario. Could you talk about that one? Yes,
that's right. This is defined as a remote evaluation of recorded video and or images, which, as you said, Tim, is a store and forward visit, also initiated by an established patient who sends in an image or a video clip to be evaluated by their doctor. And similar to the virtual check-in, to be reimbursable, the store and forward visit cannot originate from an E&M service provided to the patient prior 7 days or the following 24 hours or soonest available appointment. The provider must also get back to the patient within 24 business hours with their evaluation. And in terms of modality for this one, CMS indicated that the following follow-up communication with the patient could be done through a phone call, a video communication, secure text messaging, email, or patient portal, again, as long as the HIPAA requirements are being met. Again, just like the virtual check-in, CMS did not limit the use of this code to any specific application or specialty area, so it could be used very broadly as well. For example, for a patient sending in an image of a wound or a video clip of a neurological problem or to discuss a mental health concern. And for this code, CMS finalized the non-facility rate at $13 per visit.
Okay. So let's go to the third one. So there's one more. Can you describe how this code would work?
Yes. This third code is for interprofessional or provider-to-provider consultations. These can be conducted in real time using the telephone or video or asynchronously through the internet or the EHR. And for this service, CMS finalized 6 payment codes, then the codes tied to the modality and the amount of time being spent to help diagnose or manage the patient's condition. And it ranges from a reimbursement rate of $18 on up to $73.
Okay. So 3 new codes sort of under a new context, right? These are called technology-based services, so they sort of fall outside of traditional telemedicine regulation. Is that a fair statement, Jordana?
Yes, that is. Absolutely. They are not subject to those 1834M restrictions.
So, and just to kind of build on this a little bit more, so these are new codes that go into the physician fee schedule beginning January 1st. And so would you assume that if there's parity law in a state that the private payers would also pick up these codes and use them as well?
Well, I think certainly, historically, private payers have tended to kind of follow Medicare's lead. So I think it's a good possibility that will begin to happen once these codes go live, for sure.
Yeah. So let's jump to an additional set of provisions around remote patient monitoring. So can you talk about, again, in the physician fee schedule, what's presented from a remote patient monitoring perspective?
Yes, I think this is a very exciting area as well. CMS finalized 3 new payment codes, which will augment the CPT code 99091 that we got unbundled this year for remote patient monitoring. And what these new codes do is they enable separate payment for the full range of both professional and technical activities that are associated with remote patient monitoring. And by doing this, CMS, I think, really has been trying to fix the constraints that were set up by 99091, which only paid for the professional component, and it limited payment to physicians and qualified healthcare practitioners, which left out clinical staff. And it also required a minimum of 30 minutes of time to be spent, whereas the new professional code, 99457, reduces the minimum amount of time that has to be spent from 30 to 20 minutes, and it uses a calendar month instead of a 30-day period of time, which is making it more realistic and easier to track, I think. It also allows other clinical staff to be able to bill. And the other 2 codes that follow the technical aspects and pay for the technical aspects of remote patient monitoring include setting up the equipment and educating the patient on how to use the equipment. So this is first-time payment here. And as you can see in the slide, with these new payment codes, there's significant potential for new reimbursement for these types of services.
So just so for clarity, all of the things that we've been talking about on the physician fee schedule, the virtual check-in, store forward, and now these remote patient monitoring advances, the patient can be anywhere, right? There's no restriction. They can be in their home. There's no rural restriction. I'm just clarifying, given some of the questions that have come in. What types of technologies will qualify under the new RPM codes?
Well, CMS did not stipulate or offer any specifics in the final rule on what technology qualifies. What they did say, though, is that they're going to issue guidance. So we should be looking for something to come out from CMS that's going to help inform us and provide more information around this. But that's all we know at this point.
And can the RPM code, CPT code 99457, be billed incident to? What kind of supervision level is required?
Right. Well, CMS stated that the new CPT code 99457, which is a professional time code, cannot be provided by auxiliary personnel that are incident to a practitioner's professional services. And this is a little bit different position from how CMS chose to deal with the chronic care management services under CPT codes 99487, 489, and 490, where for those codes, CMS made an exception allowing incident to billing under general supervision. So this is a little bit different.
Does this require an in-person visit?
No, it does not.
Okay. Can you bill the RPM code along with the chronic care management?
Yes, a provider can bill both RPM and CCM in the same month for the same patient. However, when they're doing this, the time spent providing these services cannot be counted twice. So at a minimum, there would need to be 40 minutes of total time spent, 20 minutes going to RPM and 20 minutes of CCM.
Okay. So it sounds like this is significant upside potential for RPM. Is that right?
Yeah, I completely agree. I think, without the restrictions, the 1834M restrictions, the potential is very significant. There's no limitations, again, to geography, to medical setting, or specific use case. So it's really very exciting. And as we talked about before, CMS payment policy changes can often be a catalyst for change among the other payers.
Yeah. So if we stay on the track of remote patient monitoring for a minute, we just talked about what's in the physician fee schedule for next year. Let's talk about what CMS has done in the medical home, Medicare home health benefits. Can you talk about home health for a minute?
Yes. The final rules came out for calendar year 2019 and 2020. And in these rules, the home health benefits also support the expansion of remote patient monitoring. And for home visits, CMS will allow the home care agency for the first time to include remote patient monitoring as an administrative cost on the home health agency cost report. And they can do this when remote patient monitoring is used to augment the care planning process. And also, CMS finalized rules establishing a home infusion benefit that also allows remote monitoring services associated with administering infusion drugs in the patient's home. And these rules fall under the Home Health Prospective Payment System Final Rule.
So again, broad changes to telehealth payment and now for remote patient monitoring. A couple of specific questions. Which new payment policies for telehealth apply to federally qualified health centers and rural health centers?
Yeah, for FQHCs and RHCs, the face-to-face requirement will be waived, and they will be able to bill for the virtual check-ins and the remote evaluation store and forward visits. They'll use one code, which is G0071, to bill for these two services. There are some requirements that have to be met in order to bill, including there has to be at least 5 minutes of communication. The patient must have been seen at the center in the past year. The service must be provided by an FQHC, RHC practitioner. But there's no frequency limitation in terms of the billing. Unfortunately, though, there's no billing for interprofessional consults here. So it's just the virtual check-ins and the store and forward visits.
Okay. So let's jump. So what other provisions or changes were in the physician fee schedule that impact telehealth that we haven't covered?
Okay, so We've talked about a lot of these changes, again, that are not subject to the rural and other restrictions. Jumping back to traditional Medicare telehealth codes that are subject to these restrictions, we got 2 additional codes that get added to the list of approved services, and these are for prolonged preventive services. In addition, the fee schedule implemented the Bipartisan Budget Act provisions that's for telestroke and for patients with end-stage renal disease. And with regard to stroke, CMS finalized the definition for a mobile stroke unit, and they defined it as a mobile unit that furnishes services to diagnose, evaluate, and or treat symptoms of an acute stroke. So they took a broad view when they came up with this definition. Also for telestroke, CMS finalized the requirement of a new modifier, and that modifier is GO, go. So starting on January 1st, claims for telestroke services should be appended with the GO modifier. The final rule also included an interim final rule with comments that implements the telehealth provision that removed the rural requirement and added the home that came out of the Opioid or Support Act legislation. Again, that will go into effect next July. And lastly, CMS decided to continue to keep the comment period open on a separate bundled payment for treatment of substance use disorders.
Okay. Wow. So a big year. Lots happening. A very significant change in the attitude of both Congress and CMS. How do you think health systems should be thinking about these new reimbursement opportunities, Jordana?
Well, I think, Tim, that we've reached a turning point or an inflection point in terms of attitude, where policy and telehealth are coming together in very significant ways. It was just yesterday during meetings I was having up on Capitol Hill where I heard very clearly that our lawmakers are very supportive of telehealth, but we still have some stumbling blocks that we have to get ahead of. And these concerns that they have are focused around costs and program integrity. So these are the areas, again, that we need to tackle and try to address. But the new payment changes that we got for 2019 all create broad opportunities to drive new use cases using telehealth and to be able to bill for services that have been provided for free in the past. And in particular, providers can take advantage of billing, again, for stroke and for end-stage renal disease. These start January the 1st. So again, if a healthcare provider isn't currently billing for these services, this is the time to get set up and to do this. Also for home dialysis patients. With regard to remote patient monitoring, here the economics and the business model for this use case could really change things considerably. So these are really big shifts that we're seeing, and we're seeing the industry evolving much more rapidly now. There's just so much happening on a daily basis. So I think it's important for providers to be proactive here and to get familiar with the changes, these opportunities, to be able to take advantage of them on January the 1st.
Yeah. Crazy times. It's great. It's
Very
a long
exciting.
time coming. I know you've been following this for many years, particularly in your previous role at ATA. It's pretty exciting to see this sort of sea change. So, message to health systems. You know, it's time to really pay attention to what's billable and to set your systems up so that you can take advantage of these opportunities. What do you think we're going to see next year? Is this trend going to continue?
I think it's going to continue, Tim. I think we're going to see Congress and CMS continue to build on the momentum to break down 1834M. That should be our mantra, break down 1834M, to enable broad reimbursement for services. Realistically, though, these changes will likely continue to be incremental in Congress, but I think within a short period of time, we'll start to see larger chunks being addressed. And in fact, we're trying to push there. We're currently advocating around a policy change to remove that rural restriction to expand access to specialty telehealth visits that go beyond telestroke in hospital emergency departments. And we would welcome the opportunity to talk with anyone on the call today who's interested in banding together with us and working with us to move this particular policy forward. With regard to CMS, I also anticipate the leaders will continue to be proactive as they have been around technology, innovation, and build off the new paradigm that they've created with these new payment codes. And as we shift more and more towards value-based care, really the fee-for-service payment structure will become less of an anchor. In fact, we know the transition to capitated and value-based payment models is well underway, and it's certainly accelerating under the current HHS leadership. And for example, just last week, many of you may have heard as well that Secretary Azar announced that mandatory bundles are on their way back. So definitely exciting times ahead here.
So what just to sort of summarize, so CMS is going to continue to drive value-based care initiatives, and they will now be more aggressive about the adoption of telehealth as a mechanism to deliver care under value-based care models. And we talked about bundles, and we talked about ACOs, and we talked about Medicare Advantage plans. And then on the fee-for-service side, where historically there's been very little activity, we've now got both Congress and CMS taking significant steps, removing the rural restriction for stroke, for dialysis, and we believe for a bunch of other things. And so we're pretty optimistic about where things are going.
Yes, very optimistic. Yep. Mm-hmm.
So we've got, so Jordana, you probably haven't been able to see this, but there's probably 50 or 60 questions that have come in we haven't been able to address, many of which get pretty far into specific billing questions.
Okay.
I think what we're going to have to do is we won't be able to go down this list. Maybe there's a couple we can cover, and then perhaps we can encourage folks. I think we have a slide with your contact information. We can put that slide up, and we would encourage people to reach out and pose your questions directly to Jordana, and we can address those. And perhaps we'll look at a way of capturing, a broad set of questions and providing a kind of a global answer to those. So with the few minutes that we have left, let's talk a little bit about a few of these items. So if an organization's been providing telehealth services but hasn't billed yet, do you have a choice? Do you have to bill? Can you choose to not bill as you have been? What's the story there?
Well, it's interesting. If the provider is a Medicare participating provider and the service is a Medicare covered service that meets the requirements that are outlined as needed, and if the service is being provided to a Medicare beneficiary, then Medicare does require a claim to be submitted. There's a Medicare mandatory claims submission rule. There are a few exceptions, but generally it is a requirement to bill. And we know that the OIG did that audit recently and looked at telehealth claims where there was a claim submitted from the distant site, but there was no claim from the originating site. That was the red flag. And so what's the best case scenario is where both sites are billing and there's a matched, corresponding pair of bills for a particular encounter. So I would really encourage healthcare systems to look into that, and if anyone is interested in the reference around that, just please reach out to me. But again, having both sites, get familiar with how to bill and getting those claims put forward is really the best way to go.
So both sites billing, one site billing, there's an originating site bill and there is a distant site bill, correct?
That's correct, right.
Yeah.
The distant site. Yep.
Go ahead.
The distant site is the provider, the professional fee. They bill the professional fee. And the originating site where the patient is located bills the facility fee.
So do we still use the GT modifier?
Well, for Medicare, CMS removed the requirement to use the GT modifier, and so all that's needed is the place of service, which is O2, POS 02, that's used on the professional side, and then to bill for the facility fee, it's Q3014. But starting January 1st, we will have that new stroke modifier, the GO modifier, to keep in mind. But there's no GT modifier requirement for Medicare. I know it can be a little bit confusing here because Medicaid and private payers, some of them do use the GT modifier, but not for Medicare.
Okay. So there's another question that's come in going back to provider kind of national licensure. So we saw the VETS Act, which allows a physician with a single state license to provide services inside the VA across any state. Has there been any movement or discussion on the Hill about, providing more of a cross-state provider coverage capability?
I am not seeing anything or hearing anything beyond the VETS Act, and that focuses in in the federal system. When it comes to Medicaid and the states, of course, we're seeing momentum within the compacts, but that still requires licensing according to each state's rules, according to the medical boards in the states. But today we do have 3 operational compacts. That's the medical licensure compact, the PT compact, and the enhanced nurse licensing compact. So they're helping, but no, not quite seeing anything more on the federal side besides what's been happening with the vets.
Okay. Maybe we have maybe time for one more question. What if the originating site is the patient's home? Is there a facility fee for that?
There is not. So when the patient's home is the originating site, then that is not something that would be billed. So I guess that would be an exception to that scenario where there would be a pair of corresponding bills that would go out, with that code. So you wouldn't be billing for the Q3014 code if if the patient's home is the originating site.
Okay. Well, listen, I'm going through this list, and there are many more questions we haven't been able to address as we kind of bring this to a close. Do you have any closing thoughts that you'd like to share?
Well, I think, just to say that while 2018 has been a momentous year for all of us in telehealth, very, very exciting, lots of policy wins, and more than I can ever remember. So I think as we look to 2019, let's hold on to your hat, because if it's anything like 2018, it's going to be even better. So.
All right. Well, I think I think we'll bring this conversation to a close. Just a reminder, you have on your screen Jordana's email and my email. If you'd like to extend the conversation with her, you're welcome to reach out to her. And we'll have to put our heads together a little bit, Jordana, and think about how to respond to all of the additional questions. We'll have to think about maybe something we can send out or a follow-up webinar at another date.
Sounds great.
All right. Well, we'd like to give a big thank you to Jordana and Tim for today's presentation. For additional questions or information, you can also please use our email address on the screen now, feedback@intouchhealth.com, or contact us directly at the email addresses of Jordana and Tim. And then also, please visit our website found at this URL for recording of this webinar at a later date, which we will also be sending out via email, as well as a list of upcoming webinars in our series. So thank you, everybody, for joining us, and have a good rest of your day.
Bye-bye.